This
Dr.
conference will now be recorded.
Dr. Kamal, internet speed is not that good here, so I would request only the speakers should keep their cameras on. Only the one who's speaking, they can keep their cameras on.
Okay.
Amy, only
Yes,
you keep the camera on and mic on. Then you start
Okay.
your ATLS. Coordinate with Shamla. She will run your slides. Okay, we will stay in the background with just mics on. Is that okay?
If you like, yeah.
We will just turn the camera off.
I'm hoping that Abdul is going to come at some point to go through some cases with me.
Don't worry, I'm there in a minute. That if you turn the camera off as well, so the speed gets a bit better.
Oh, wow.
So Ahmed, will you please introduce the faculty at MDMI to Amy? Just tell them a bit more background.
Well, they've all gone.
Yeah, I think they're still there. It's just
Okay.
So your slides you can see. So there.
Grand.
Right, it's Dr. Sumera, our pediatrician. Then in the front row, there are medical officers, Dr. Adil, Dr. Amar. Then in second row, again, there are medical officers, Dr. Sophia and Dr. Nafisa. And there are 2 or 3 nurses with us and an anesthesia technician in the last.
Oh, lovely. So my name's Amy. I'm one of the A&E doctors that works with Norman at QMC in Nottingham, UK. And Norman's asked me to go through some trauma teaching for you guys. Going to go through the basics of trauma, present a few cases, but I just want you guys to be a bit more interactive as well, so you're not just sat there listening to me talk for hours. So if everybody can interact back, that would be great. Is that all right? Yeah? No? Okay, fine. So so Shamla, are you going through the slides then?
Yeah, I'll help you with it. You can just tell me when to move on.
Okay, fine. So if we go through on the first slide, so our objectives today will be going through what is trauma, going through the basics of a trauma team. We're quite lucky in the UK to have major trauma centres set up, so we can have kind of a stepwise approach to seeing different people with different types of trauma. We'll go through the concepts and the principles of the primary and the secondary survey, what's important in each. And then as an adjunct to that, we'll go through the primary management of life-threatening conditions and what you should be doing for them within your primary and secondary survey. I was hoping to show you a video of a mock trauma call, but we can't get it downloaded. So I can probably, once I've got it, email it to you guys to see later on if that's what you'd like. So yeah.
So MDMI Muzaffarabad, are you getting the clear video and voice there?
Let me just close the door.
Yes, voice is clear. Voice is clear.
Sorry, voice is clear. So yeah, please pitch in whenever you have any questions or you can't, if you are having problem with the video link. Go ahead, Amy.
And don't just sit there for the next 2 hours being bored.
Please feel free. We know it is not a very good link. Issues with internet even here. So please feel free.
Okay, so if we go on to the next slide, this is a pie chart. This is taken from where is it from? I think from the World Health. These are different types of trauma as categorized from the most common to the least common. I've blanked them all out because I want you guys to just have a couple of minutes to think which you think is the most common types of trauma.
Can you please share this file with me so that I can open it here? Yeah, now I can see pie chart. Now I can see pie chart.
Sorry to interrupt, Amy, it's Farhan here. Shamla, will it be possible to share email these slides to Ahmed so that he can, or share it in the WhatsApp group so that there is no delay while them being transmitted via internet?
If you give me the email, I've got it on my email now. I can email it to.
It's already sent. It's fine, Dr. Amy. I have already sent it to them. Maybe because it was done just right before the meeting. Maybe it's not come to their notice. I just shared it with them. So they can just check their email. Ahmed, just please go ahead and check your email. It should be with you and Babar.
Sorry, that was my fault. I had a bit of a problem with the slides.
That's all right. That's all right,
okay.
Dr. Amy. You can continue.
Okay, so if you guys can you see the pie chart okay? Yes.
No.
No.
Is it saying now, Ahmed?
Yes, Amy, we can see the pie chart now. You can please continue.
Okay, so from the pie chart, there's obviously different types of trauma. The first and the most obvious one would probably be road traffic accidents, which is, if you go to the next slide, is the most prevalent. So that accounts for 23% of road traffic accidents. And if we just flick through the next slides, kind of the next 3 or 4, they'll all pop up. So after road traffic, you have suicide and homicides. You know, a trauma call we could see in the UK would be somebody who's had an attempted hanging or a shooting, not so much here. Then a large number of our traumas that we see, which you may not expect to see, would be falls. So we have quite an elderly population, and they obviously fall quite a lot. So we would constitute fall down the stairs, or even when men go out to do some DIY and they fancy going up a ladder into the roof and they fall out of the roof. They do constitute quite a lot of our trauma as well. Following on from that, we have drowning, fires, and poisoning as the next. If you just skip through again, the next kind of to number 10.
It's seeming to be stuck. Just give me a second.
No. So, Ahmed, can you ask the staff, the doctors and nurses there at Muzaffarabad, what type, does this corresponds to the pattern of trauma there, or is it different?
Yes, Dr. Adil, please go ahead.
It's almost the same.
Reflect
Almost
on
the
it.
same. So do we see a lot of suicide and homicide there? It looks like a bit higher ratio.
Okay, so then I've just put here, so the other, which does constitute 21%, seems quite a lot, but actually if you break that down, that's from choking, asphyxiation, hypothermia, hyperthermia, and natural disasters. So from this, you can obviously see that there are lots of different types of trauma, and somebody who has been caught in a fire is going to have different injuries to somebody who's been in a car accident. So it was after there was a big plane disaster that I can't remember who it was, but they invented ATLS. So that's Advanced Trauma Life Support, to have a method where you can go through and identify life-threatening injuries. And it was based on the trimodal death distribution, which basically shows that there's 3 peaks of death following a trauma injury. So the first peak would be in seconds to minutes. So that would be with somebody who's had a traumatic cardiac arrest following or a severe brain injury. The minutes to hours. Oh, sorry, someone's just at my door. 1 second.
I think.
Sorry, it was the postman. The second one would be minutes to hours after the injury. So that would be kind of by the time that you've got to the hospital, and if there's been a bit of a delay. So that would be things like ruptured spleen, subdural bleeds, and then days to weeks would be after the injury has occurred. So rib fractures leading to chest infections leading to sepsis, or multi-organ dysfunction. So if you go on to the next slide. Examples there of where things can go wrong, and where we would come in would be the minutes to hours. So as emergency department doctors, we're looking at the minutes to hours, the second peak. Pre-hospital medics would be looking at the seconds to minutes, which is the first peak, and then the trauma team or the surgical team would be looking at the third peak, which would be days to weeks. So if you follow the next slide, we basically have the golden hour, golden clock. So
here at this stage, just I want to pitch in, because the infrastructure is such in Pakistan that we might not have very quick response to any trauma. So sometimes, and most of the times, likely the trauma patients will come to our emergency department or any emergency department, not within an hour. So initial hour treatment might likely to be in where that accident happened. So we don't
but that's all right. That's all right, Norman. Amy is trying to say that hour is important. Of course, if you miss it or whatever, that's well, that's not fine. But you want to try your best within that hour. So it doesn't matter if we get delayed, then we get delayed. But at least that hour is important, isn't it, Amy? Is that right?
Yeah. So obviously there's what you're going to be doing in the first 10 minutes to the first 60 minutes. You're providing life-saving intervention, and with a more acutely unwell patient, and they're certainly more unstable. So if you just go on to the next slide. So we here, I don't know if you can see it very well, but we here in the UK, we're really lucky that we, like I said, we've got trauma centres. So we'll have a major trauma centre, and then we'll have district general hospitals that are kind of have some trauma experience. So this here is just a layout of what the ideal trauma team would be. So this is the team that would be needed to run what we would call a red trauma call. And as you can see, there's a lot of people. Probably the amount of people that you have in your room right now would be running a red trauma call with one patient right in the middle. So it can be a bit hectic, but this is why we have set jobs and roles and responsibilities, as it were. Can you guys see that slide okay? No.
I think speaker is
Have
off.
they got their mic off?
Yes.
Oh, okay.
Ahmed, if you keep your mic on so you can interact.
All right.
So can you guys see that slide okay? Yeah. Okay. So moving on to what we would do as the primary survey then. Oh, just go back one. Back a slide. There we go. Okay. So do you guys all know what ABCDE stands for in trauma? I couldn't
Airway,
quite hear.
breathing, and circulation.
Yeah, okay, so if we go through the primary survey, so in addition to ABCDE in an unwell patient, we have C first, which is the catastrophic hemorrhage. So this is basically what's going to make you more unstable first. So if you go through the next, click through the next to get them all up. Yeah, there we go. Okay, so yeah, so if you are bleeding catastrophically from a limb fracture dislocation, or if you have had a penetrating injury to the abdomen or the chest, there's no point in us securing your airway or checking your pupils because you'll probably die. So this is why we go through this in a stepwise manner to stabilize the most life-threatening problems first. And in trauma, we try and stabilize and then move on and then come back and reassess. So if you have somebody who has an unstable airway, you would ask an anaesthetist to secure the airway for you, move on to breathing, and then always come back to airway and say, have you secured the airway? Are you happy with the airway? And then move on. So it's a continual assessment, reassessment, intervention, reassess, and then carry on. So it's always in a big circle, basically. So if we go on to catastrophic hemorrhage, and the next slide. So I always remember it in this way. So blood on the floor and 4 more. And we'll talk about these in a little bit more detail later on. But basically there's external sites of bleeding and there's 4 internal sites of bleeding. So head, chest, tummy and long bones. So 5 in total. But I just find that quite a good acronym to remember. Okay, so if follow through to the next slide, but afterwards. And again, yeah, okay, so how you would assess the airway. So I now have a patent airway because I'm speaking. I can maintain my airway enough to be able to phonate my sounds. So a good way to quickly assess somebody's airway in trauma is ask them a question. So, hi, I'm Amy, I'm one of the doctors. Have you got any pain anywhere? And if they are an alert and conscious patient and they can respond appropriately, then you can be happy at that moment in time that they have a patent airway. If they don't have a patent airway, can you hear anything? So can you hear a stridor? Can you hear any gurgling? This may indicate some inability to maintain their airway. Have a look. So can you see any foreign body? Can you see any trauma to the face? So have they got any facial bone fractures? Have they got any burns to the face? And burns to the face is really important in trauma and the airway, because if you have external burns, you may have burns internally, and then may pose a risk to the patient's airway. So airway and burns go really close together, and if you're in any doubt about the integrity of the airway, then get somebody who is airway trained to manage it, so an anaesthetist or a A&E doctor, somebody who can manage that airway until a definitive airway can be put in place. And then as a caveat to the airway, always remember the C-spine. So usually in a head tilt chin lift, that's fine if you are not suspecting any cervical spine trauma. But if you are, then you need to keep the C-spine in a neutral position and manage the airway, you know, appropriately. So if you follow on to the next slide, you can see here that there's a patient here on a spinal board, and somebody at the top end is maintaining the airway, the C-spine in a neutral position whilst assessing the airway. So you don't want to hyperflex the neck here to create a further injury. Does that make sense? I don't really. Yeah. Okay. So then, if we move on to breathing, just skip through. I left a blank slide in case. So skip through again. Okay. So just because a patient has a patent airway, which means air can pass through, it doesn't necessarily mean that the adequacy of breathing and ventilation is enough to perfuse all of your organs. So to ventilate yourself, you have to have adequate function of the lungs, the chest wall, the muscles, and the diaphragm, all of which can be injured in trauma. So for the primary survey, you will inspect, so look at the chest wall. Is there any evidence of blunt trauma or penetrating injury? Has somebody been stabbed in the chest? Can you see any bruising, a seatbelt mark across the thorax? And also at this point, you can see the oxygen saturations on the monitor. You then go to palpate the chest. So is the trachea central? Have they got any pain when you're pressing on the chest wall? Could indicate some underlying injury. And can you feel any deformity of the chest wall? And then you go through to percuss and auscultate. And in the first part of a trauma call, in the primary survey, you're only really able to do this on the anterior aspect and down in the sides, so into the axilla. We can't sit the patient up or roll the patient over to do anything posteriorly in the primary survey. So all of this is anteriorly and round in the axilla. So next on to breathing next. So at this point, always give a patient oxygen. So even if their oxygen saturations are within acceptable limits, this is something that's really easy, really quick to give, and it can, you know, improve patient outcomes in the long term. So 15 litres via non-rebreathe mask. So moving on to circulation. And again, okay. So this is an assessment of the hemodynamic status of the patient. So do they have enough blood in their body to perfuse their organs? And this can be assessed by seeing the level of consciousness of the patient. So if the patient is drowsy, then it could be due to reduced perfusion of the brain. And alongside that, you can also see perfusion to the skin. And then observations are really useful here, so pulse and blood pressure. So pulse and blood pressure are really useful in trauma to help us see the trend of how a patient is doing. So if someone comes in and they're tachycardic, that could obviously be due to lots of different things, but if they're getting more tachycardic, then that's obviously not good. but if their pulse over time is settling as we are intervening and providing life-saving interventions, then it's the trend that we look for. And like I said earlier, blood on the floor and 4 more. So these are your sites of hemorrhage that you would be concerned for, not just in trauma, but in everything. So next, as part of the circulation, oh, just skip back a slide. Yeah, oh, forward one. There we go. So as part of circulation for every single patient who comes in as a trauma, we want to have vascular access. So there's no point in deciding to give things if we can't give it. So we'd want 2 large bore cannulas, ideally in, in a large vein. So if you can put it in the ACF, then that's great. If you can't get cannulas in, then we use IO. Is that something that you guys have out there?
Can you please repeat the question?
Yeah, so do you guys have intraosseous access?
I don't think so. They are aware of intraosseous access. It's not very commonly used in Pakistan. So basically,
Okay.
intraosseous access वो है कि आप जब आपको IV access नहीं मिल रही हो पेशेंट की, फर्ज करें कि ट्रॉमा का पेशेंट सीवियर शॉक में आता है तो आपको कोई IV access नहीं मिल रही है, तो यहाँ पे यूके में हम लोग क्या करते हैं कि जो बोन्स होती हैं ना, जैसे आपकी टिबिया है ना, एंटीरियो मीडियल सरफेस ऑफ द टिबिया में एक स्पेशल डिवाइस होती है, उसको कहते हैं इंट्राओसियल कैनुला कहते हैं, तो वो डाल के उसके थ्रू आपको ना इनिशियल रिससिटेशन दी जा सकती है, और उस रिससिटेशन के बाद जब आपका पेशेंट को थोड़ा सा मतलब ब्लड वॉल्यूम वगैरह बढ़ जाता है तो फिर आप नॉर्मल IV एक्सेस करके कंटिन्यू करेंगे. So Amy, I've just tried to explain them about a little bit about intraosseous access.
Okay. Yeah, so
okay, Amy, I think they've got a question as well.
Okay, yeah.
Was IV line access नहीं हो सकती, establish नहीं तो क्या हो सकते हैं intraosseous intraosseous उसके अलावा टीबिया में करते हैं स्पेशल डिवाइस,
टीबिया में कर सकते हैं, ह्यूमरस में कर सकते हैं, वेरियस साइट होती हैं, इस पे वी कैन हैव ए डिस्कशन इन अ डिटेल सेशन डिफरेंटली. तो as long as you're aware of what is intraosseous access, आपको पता होना चाहिए कि अगर IV access नहीं मिल रही है तो what else you can do.
Happy? So we, although we have intraosseous access here, we don't use it often. It's just something that to be aware of, that if you can't get access, then it's something that you can do, and you can use it exactly the same as a cannula. So you can give fluids through it, you can give blood through it, you can give medication through it, and it literally is like a drill. So it's really simple to use. So once you've got your access and you've got your bloods, you send off a full set of trauma bloods. So using a venous blood gas as a point of care testing is really useful in trauma. We do a beta HCG for females as pregnancy, and would cross match or group and save most trauma patients that come in, because they may need blood now, and if they don't need blood now, then they may need it down the line. So next but one. So next is your disability. So here, this is your neurological examination. So next slide.
So Annie, will we do hepatitis B screening as a primary survey for trauma patients?
Say again, sorry.
Like we used to do.
I can't hear very well.
Go ahead. Will we do here, like?
I think what I got, Amy, they are asking because hepatitis is quite common in Pakistan. So they were asking whether infectious screen is a part of a trauma.
Oh. Okay, so
I think this is what
I don't know what what it would be like for you guys out there, but we wouldn't do an infection screen as part of trauma bloods, but they would get an FBC, so a full blood count, Usenes. They would also get a liver function test and coagulation test as well. But as part of a bloodborne virus screen, we wouldn't routinely do it, no.
Yeah, so Ahmed, what you need to do there is take every precaution. Just assume that every patient is positive until proven otherwise. So just take the normal precaution which you take with any infective materials, you know, double gloving or taking care with the needles and its disposal. So no, regarding your question whether to do an infectious screen as a part of trauma, no, but take all the precautions which, you know, assuming that every patient is positive.
Okay.
Go ahead, Amy.
Yeah, definitely. I think also as part of an infection screen, I know here, certainly for things like HIV, we actually have to get a patient's consent to be able to do the HIV test. I don't know if it's the same for you guys out there, but if consent becomes a problem and somebody's, you know, got an altered neurological state, then you can't gain their consent to do certain tests. So like Norman said, certainly keep all of your precautions that you would do anyway. So moving on to disability. So this would be the neurological examination from the GCS, so the Glasgow Coma Scale. You'd look at the pupils, and then also from the venous blood gas, you would see their blood glucose on there. So if you flick through to the next slide. So I want you guys, before I give you the answer, to have a couple of minutes to see if you can fill in the Glasgow Coma Scale here, from 1 being no response and then 4, 5 and 6 being the most alert. Can you guys fill it out or think in your head what you think it is, and then in a couple of minutes we'll go through it. I'm just going to go and let Abdul in as well, who's coming to do some cases in a second.
So Ahmed, yeah, please, yeah. Do you do GCS frequently? Assess patients GCS, Glasgow Coma Scale in Zafra.
Yes,
so
sir.
just go through it. You know. So one of you, if you interact with Amy and tell them, you know, don't worry if it is wrong or right. Just give your idea what you think of GCS and how to scale somebody. Assess the GCS.
So, sir, we'll begin with eye opening. 1 means there is no response.
Yeah.
Hi guys.
Sit down. So this is one of my colleagues, Abdul. He works at Queen's with me, and he's going to go through, once we've gone through the primary survey, we're going to go through what you would do next. So you guys happy with what you think so far for the blanks?
Please go ahead and answer.
So I'm going to tell one by one all of these three. Eye opening, 1 means there is no eye opening.
Yep.
Good.
Start. So the card, 1 means no eye opening. 2 is then 2 is pain to pain. 2 is to pain.
Yeah.
Eye opening to pain. 3 is eye opening to voice.
Yeah.
And 4 is spontaneous. Spontaneous eye opening.
Good.
Yeah. So if you press the next slide, that will confirm.
Wait, can you not control the slides?
No, she doesn't. Oh no, go back one. Ah, go back one. Okay. Now verbal response. No.
One will be no response.
Yeah.
Two will be
Mistake, I guess.
Incomprehensible sounds. Two. I'm just guessing this one. Incomprehensible sounds.
Yeah, you're getting them right. Keep guessing.
Three was inappropriate words. Four was confused, and five was I think normal, well oriented in time and space.
Yeah, well done. And then the last one, motor. If you skip one, if you go to the next slide, yeah, and so the hardest one that people find.
So one will be no response. Two will be decerebrate, or decerebration. Three, decortication. Four is withdrawal. Withdrawal to pain, flexible withdrawal to pain. Yeah, five will be localized pain, and six will be normal response. Moving all four limbs.
That's right. So if you just go to the next slide. There we go. That's so yeah, you got them all right. So this is something that's obviously really good to see somebody's neurological status. And if you just flick through to the next slide, I'm just going to explain the motor response M2 and M3, just because some people find this a little bit difficult to remember. So M2 would be a decerebrate posture. So you're kind of posturing away, everything's extended and rotated away from the body, and you can appear quite rigid. So this really isn't a good posture to have at all. Can sometimes show that you've basically coned. And then M3 would be a decorticate posture, so everything's kind of coming towards, everything's rotated into flexed upwards and towards the brain, as it were. So these two sometimes get a little bit mixed up with decorticate and decerebrate. But if you just remember what they look like, you don't necessarily have to remember the words as such. So then if we go on to exposure, yeah, so you want to expose the patient as much as possible. So if they're clothed, cut their clothes off, have a look. Again, you can only do it anteriorly and down the sides in the primary survey, but you can look for any occult injuries, any stab wounds or penetrating wounds around the sides. You want to check a patient's body temperature, and then once you've assessed them completely, make sure to cover them up again with blankets or sheets so that they don't get cold. But obviously you can't assess a patient's spine in the primary survey because you're not log rolling them, and that's later on down in the secondary survey. So this interventions that we would do during the primary survey. So we've gone through C, A, B, C, D, E, and like I said earlier, as you are assessing them, you are wanting to either treat the abnormalities or put things in place to start treating them. So if you find something wrong, you want to fix it and then move on, or ask somebody else to fix it. So we're next slide. Okay, so catastrophic hemorrhage. So in this, you would want to put direct pressure on the wound. So if somebody is bleeding from the abdomen or the chest, you want to put direct pressure control, and if available, you will have topical hemostatic dressings. So these are potentially used a little bit more pre-hospitally, but these have hemostatic components impregnated in the dressing, so that it actually helps local coagulation. Limb tourniquets, again, this would be done pre-hospitally, I would imagine. But if somebody has had a traumatic amputation and their leg is, you know, bleeding, I would hope that they would have a tourniquet put on. If there's not a proper tourniquet, a makeshift tourniquet. And it's really important in this to notify what time the tourniquet went on, because if there is any possibility that you can save the limb, and you've put a tourniquet on and left the tourniquet on for 2 hours, then the limb might not be salvageable. So it's really important to know what time that tourniquet went on. Then within the emergency department, if they had a major hemorrhage, we'd want to consider a blood transfusion. So again, we're really lucky over here to have major hemorrhage protocol. So before somebody comes into hospital, we can activate that, and we can actually get blood down in the department before the patient even arrives. Is that something that you guys have there, like major hemorrhage?
Yes. Yes.
Yeah. Okay. And when a patient's coming in for pre-alert, do you guys get pre-alerted that there is a trauma coming in, or do they just arrive with you?
Sometimes, most of the times they just arrive.
Yeah, so obviously because practice is quite different in different places in the world, you've got, in England it's quite standardized where most of the hospitals have the same system and most of the ambulance services have the same reporting system that they use for, you know, over the radio, or they use by a mobile phone. Obviously with you guys, am I right in saying that you're not a trauma center, are you?
No, this is the, you know, Tendali Hospital is not a major trauma center, but even in the major trauma center, we don't, I think in Kashmir and Pakistan, we don't have like the facilities like here, like ambulance services, not very well developed. So I think it's just people turn up just like randomly, and occasionally you may like just by chance you may get a phone call by somebody, but it's not a routine practice.
Okay, and where are you guys exactly?
This is in Muzaffarabad, Azad Kashmir.
Okay.
Almost about 2 hours from Islamabad.
So it's really unlikely that you guys are going to have any kind of pre-hospital, you know, system going on there, because I've been to I worked in Bangladesh for a while, and the patients were just turning up like that, and some of them had really catastrophic injuries as well from railroads and from motorcycle accidents specifically, because you know, this, you know, you guys know how the road is over there. So it's really important that so that, like Amy was saying about tourniquets and things like that, most of the time someone's just going to drag, you know, a bleeding patient into the hospital. So it's really important that you guys are able to identify quickly a source of bleeding and then stem it as, you know, as early as you can. And as she said, there's, you know, there's basically 3 different types of bleeding wounds. You've got a limb wound, and then you've got a junctional wound, and the junctional wound is what can happen in the shoulder or in the groin, and you've got a body wound, so that can be in the chest, in the abdomen, or in the head. Now, a limb wound you can control with a tourniquet. So what you do is you apply the tourniquet proximal to where the wound is. So if you've got, you know, a bleeding arm, then you'd apply it above it, and and what you do is you apply the tourniquet, but it has to go on so tight that the patient, usually they're complaining of the pain of the tourniquet and not the actual injury. That's how tight it has to go. because you need to stop the arterial bleeding. The aim is to stop arterial bleeding. So you keep on tightening it until essentially the limb will go ischemic. So if any of you ever, tried it on yourself, then you'll know how painful it is. And you have to apply the tourniquet so that it stops the arterial bleeding, the blood supply to the limb. Then you've got junctional wounds, and junctional wounds are very difficult to manage by yourselves. You're going to have to get the surgeons to help you, especially vascular surgeons, your general surgeons over there. They'll be the ones that will have to deal with that, because you can't really stop a vascular wound from bleeding in the emergency department with the stuff you have. Usually they have to go to theatre. The closest you can do, if you have Celox, do you guys have hemostatic dressings there?
Sumaira, Adil, do you have any kind of tourniquet you use for trauma patient, or do you improvise?
Trauma centers we have, not here, not in this hospital.
Okay, so I think there's something which.
Sorry to interrupt,
Yes.
Abdullah and Amy. I must say we are all enjoying your talk. As far as the resource at MDMI is concerned, the tourniquet facility, yes, we will have it, but in terms of hemostatic dressings or any products which will immediately stop active arterial bleed, unfortunately, we don't have that facility. Obviously, if surgical intervention is required, those facilities are available in certain hospital in the local vicinity. And if one of us is there at that time and that trauma happens to come, then yes, obviously we could manage it as a surgeon. Thank you.
Yeah.
That's the important thing to say with, the differences here. So, like, we're quite lucky that we do have tourniquets and hemostatic dressings that we can manage a patient with here. But with you guys, if somebody was having a catastrophic hemorrhage and they were in shock, then you really, you need to identify the source of bleeding and get them to theatre almost as soon as possible. Because ultimately, if you don't get them to theatre and you don't have anything else that you can use, they, as you probably are aware, they will die. So you kind of skip the rest of the primary survey and get them straight to theatre, because if you go through the rest of it in detail, then by the time you've decided to get them to theatre, they're not going to have any blood left for you to get them there. So you would say, fine, they're actively bleeding, they're hemorrhaging from a great vessel injury. We'll get them to theatre now and we'll sort out the rest when we get there. So if we move on from hemorrhage, so this was the major hemorrhage protocol that we have here. So we can give a mix of packed red cells, which is essentially the red in the red blood cells, and we can give FFP, which is the fresh frozen plasma, which is mostly water, can restore blood volume and can provide plasma coagulation factors. And then if a patient is bleeding and they have a coagulopathy, you can give them cryoprecipitate, but the cryoprecipitate does take time to get out of the freezer. So in the major hemorrhage protocol with a pack 1, you would give almost 1-to-1 ratio of red blood cells to FFP. You give slightly more red blood cells.
Do you guys have a blood bank there?
No.
No. Okay. Yeah. So in that case. In that case, either you'll be able to source O negative blood if you guys have it, but you might not, or you just need to get the patient off to a proper center as soon as possible. The patient's bleeding, that's actually really bad in that situation, because it might even be that one of you has to go along with them, just with his hands on the wound. In that situation, I don't think
we also don't give a lot of fluid resuscitation in trauma, because we know that fluid doesn't really have essentially any nutritional value. All it does is increases the blood volume. It doesn't actually increase any of the goodness in the blood, essentially. So we would try and give maybe a litre, no more than 2 litres at an absolute push if we didn't have anything else. So it just obviously depends what you guys have and what you can get by with.
So yeah, go on.
Yeah, okay, so if we move on to the next slide, so airway and C-spine. So if a patient has a threatened airway, you want to protect their airway. And you want to do this as soon as possible by somebody who is able to do it, whilst maintaining C-spine precautions. So if a patient has facial trauma, if they have burns, if they have a reduced GCS or an altered neurological state, you want to protect that airway as soon as you possibly can, because if you haven't got a patent airway, then there's nothing else that you can do later on down the primary survey. And with an addition for the C-spine, if a patient has a dangerous mechanism of injury, if they're complaining of neck pain, if they have any altered neurological function in their hands, their feet, their legs, if they have a sensory level, then you would want to put C-spine precautions in place, which would be a collar and then makeshift blocks. So if you don't have blocks, then you can use pillows or blankets, just something to keep that C-spine immobilized.
So does everyone understand what it means to immobilize the cervical spine? What you'd be doing is you'd be getting, rolled up towels, or you could get rolled up pillows, put them either side of the patient's neck, just to make sure that they keep it steady. This is obviously really important in high impact trauma, in sort of trauma like motorcycle accidents or car accidents and things like that, where there's a threatened cervical spine injury from the impact.
Whoa. What is it? Okay. Okay, so if we move on next. So we'll move on from airway to breathing, I think. Okay, so this is just the C-spine immobilization. So this down here in the bottom is what we would have with collar and blocks. So in an ideal situation, you would keep the C-spine in a neutral position. The patient would be supine, so they'd be lying on their back. You'd have a cervical collar, so they can't move the head up or down. And then you'd have blocks, so they can't move at all this way or this way. And then for ease of patient transfer, we'll get them onto a spinal board. So instead of having to log roll a patient, you can just lift them and move them, which is something that's useful in transferring a patient and then reducing the risk of making their injury any worse by inadequately log rolling them. So I think next is breathing. We move on. Okay, so this is getting into like the more interesting stuff now. The most interesting things, I certainly find that a trauma patient are found in the chest, and we're going to go through 3 or 4 life-threatening emergencies essentially that would be associated with trauma. So the first one here would be a tension pneumothorax. So does everyone know what a pneumothorax itself is?
Yes.
Yeah?
Yes.
Okay, so okay, good. So essentially, a pneumothorax is, where you have air between the in the pleural cavity, and you can have different kinds of ones. So a simple pneumothorax, a tension pneumothorax, an open pneumothorax, or a hemopneumothorax. So here with a tension pneumothorax, you would have the normal signs of a pneumothorax. So resonant to percuss, reduced air sounds, but in that you would have tracheal deviation away from the affected side. So the pneumothorax pushes everything in the mediastinum, including the trachea, away. You may see the patient really kind of gasping for breath, because not only have they got a collapsed lung on one side, they've also got a squashed lung on the other side.
What this means for you is you see the patient and he's struggling to breathe, essentially. You're going to look at him, a serious pneumothorax, you can almost tell from just usually one side of the chest will be moving, and when you ask him to take a deep breath, either he will not be able to take a full deep breath in, or he'll be very, he'll be struggling to do it. And obviously, if you have a SATS monitor on, if you have a blood saturation monitor on, then you'll notice that the blood saturations are, they're not as high as they could be, even if you're putting oxygen onto the patients. So this is one of the emergencies of the chest. There's there's 6 related to either air or blood being where it shouldn't be. The first one is the tension pneumothorax, where the air is collapsing one of the lungs. The next one would be a hemothorax, which is where. Okay, go on. Next slide.
No, so just so the treatment for this would be. So the treatment for this, depending on what equipment that you have available, so you can do needle decompression. Is everybody familiar with that?
Are you getting a good signal there in Muzaffarabad?
Yes, sir, we can hear it clearly. Actually, I have experience in peds. We do needle therapy in children. I don't know about adults.
Adil, do you do it there?
Yeah, so there's basically 2 options that you have for treatment for the tension pneumothorax. Is using a scalpel and essentially a chest drain, or even just a scalpel and your finger, because if the patient has a pneumothorax, then they're going to be quite sick, and you're going to need to move them to a properly equipped hospital. So the safest and most preferred option is for you to do a thoracostomy, which is where you make a hole in the side of the patient's chest, and you essentially put your finger in, and you check the lung is up or not. When you make the hole, you'll get a hiss of air. It's a very loud hiss of air, and the patient's breathing will immediately improve on the spot. And essentially, this is the fastest and safest option for the patient, because once you have a hole in the patient's chest, they can no longer have a tension pneumothorax. They may have a pneumothorax, but they won't have a tension pneumothorax, which will kill them. And then you've bought yourself some time where you can transfer the patient off to a proper hospital that can actually deal with the situation properly. If you have chest drains over there, then what you do is you put a chest drain into the hole that you've just made. It's essentially a tube, and Amy's got a video for that.
So if you just follow on to the next slide, so these would be the bony landmarks for your different procedures. So your needle decompression would be your second intercostal space in your mid-clavicular line. Use any kind of needle that you can, a cannula, a blood-taking needle, anything that's going to put a hole in the patient's chest to let air out. And then you can, for the chest drain and the thoracostomies, have in what we'd call a safe triangle. Is everybody aware of the safe triangle anatomy?
Safe triangle.
Yes.
Yeah, that'll be so. Essentially, what you have to do is you place the patient in the position diagram over there. Obviously, the patient's struggling to breathe at this point, so you have to be quite quick with it. Clean the patient, and you identify the safe area where you can put your scalpel and make an incision. So essentially, it's the mid-axillary line is the back of the safe triangle, and then anterior to that is the line moving up underneath the serratus anterior muscle, and it's bordered by the 5th intercostal space at the bottom. So it makes a triangle on the patient's chest. Here. Yeah, so essentially it's a triangle like that. And that if you make your incision over there, then you're unlikely to hit any you're unlikely to hit any organs or anything. Say again, sorry?
I mean, just repeat this safe triangle. We didn't get this.
Okay, so the boundaries for your safe triangle
I can demonstrate on you.
are the mid-axillary line,
Okay.
and that's the posterior boundary. The anterior boundary is the pectoralis major muscle, or the serratus anterior. Okay, which is the anterior boundary. And then the inferior boundary is the fifth intercostal space.
Or in line with the nipple.
Or in line with the nipple. If the, sometimes you have a large patient and you can't feel the intercostal space, so you just make a line from the nipple going straight to the side, and that will be your inferior boundary. And
you can also use the latissimus dorsi.
Yeah, and
I mean, use a knife on Abdul.
Say again, sorry. I'm not going to let Amy stab me. But making your incision, you want to make a solid incision, so you don't want to just be delicate with it. You want to make, you want to make an aggressive sort of 2 to 3 centimeter incision, and you want to go as deep as your scalpel blade will go, all the way in. And then what you will need is your dividers, and you're just gonna blunt dissect all the way down until you get to the pleural space. Now, as soon as you get to the pleural space, you'll feel it. It's going to be resistance against you, and you have to push quite hard until you break through. As soon as you break through, you hear a loud hiss, and the patient immediately improves their respiratory function.
Right.
Yeah, just because I worked for a short period there in Muzaffarabad, I think it's very important to put the chest drain in. But when I was there and later on, when I went there for teaching, people are a bit reluctant to put the chest drain or do any interventions. So if somebody has a significant trauma and a significant chest injuries, even if you have a doubt, just put the chest drain in, because that's likely to benefit patient more rather than harm. So all you have to do is to just make sure, familiarize with yourself with the triangle of safety and the procedure itself. Use a lamb or a sheep to practice it, but it's very important. Chest drain is something we often miss there.
So it's really important that you guys are you're confident when you do this, because it's very easy to be scared of, oh my god, I've got a knife, I'm stabbing the patient. But you have to remember, this patient is going to die unless you do that. So you have to be, just be brave and just attack. Use your scalpel aggressively and get into there and make the hole. As soon as you have the hole, the patient will no longer tension pneumothorax, and his breathing will improve. If you have the chest drain with you, you put the chest drain in and you just suture around it.
Okay, let's move on. So the next one will be an open pneumothorax. Okay, so this is usually due to a penetrating wound, and the difference here is that you could hear movement of air through the injury. So as a patient breathes in and out, you could hear air kind of hissing in and out.
So specifically with an open pneumothorax, is commonly referred to as a sucking chest wound. You often get this with gunshot wounds. You can have it with a stab wound as well, but remember what we just did beforehand, we've also just created an open pneumothorax. The specific danger with this sort of open pneumothorax, which is not created surgically, so what I mean by that is, someone's been impaled, or they've had, something, a bullet go through their chest. In this particular case, what will happen is, when the patient breathes in, the air will come in, but when they breathe out, it will close itself. And so you get a buildup of air on the inside of the chest. So as the more they breathe, the worse the pneumothorax gets. And this is why it's called a sucking chest wound, because the air comes in, but it doesn't come out again because the hole is jagged. So for this, you have to dress it immediately using a chest dressing.
So the important thing to say with the dressing is that you tape it on 3 sides, not 4 sides. If you tape it on all 4 sides, you've essentially created a closed circuit, and you've almost mimicked a tension pneumothorax. So you would cover the wound, you'd have the dressing overlap the edges and tape it tightly on 3 sides. So when you breathe in, air doesn't come in.
Yeah, so what this means is by putting the 3 sides, the 3-sided dressing on it, this reverses what the wound is doing. So the wound is only letting air in, but not out. But by putting the 3 sides in, you prevent air from coming in, but you allow air to escape. And of course, what you need to do is you need to close the wound as soon as possible, and you need to place a proper chest drain below it. Usually, you should not put a chest drain in the same wound. This is because the wound is contaminated, and the wound is also, it's not a surgical wound, so it's jagged, and you don't know if there's, a bullet in there or some other, piece of, well, anything, any foreign body.
Okay, so next slide.
Mm-hmm.
So the next slide is on a hemothorax. So I have put a link here to a video, but if the connection isn't very good, you can watch it in your own time. It's a kind of a 2 minute, actually it's a bit longer, a video on how to put a chest drain in that they're doing on a mannequin. But it's basically what Abdul said. So here, this patient's got a hemothorax. So the difference here from a pneumothorax when you're examining the patient is that it would be dull to percuss, predominantly in the bases. And you may have signs of circulatory shock as well because you've got blood in the chest. So again, the treatment here is a chest drain. And I don't know if you can see the diagram, but it's basically the same as what you would do for a thoracostomy, but you would then just use your your pincers or whatever you've got to clamp to push the drain in.
Yeah, so it's essentially the same treatment because the same problem is going on. You've got blood in the cavity where it shouldn't be. But there's a problem with this because if you've got blood in the cavity, it means the patient is bleeding, obviously. And the main places where you can bleed from in the chest can be large vessels. So you need to be careful. And if the patient is in shock when this is happening, then this implies there's going to be a bad outcome and you need definitive surgical management. So you need to have surgeons on hand, or you need to get the patient straight to a surgical facility.
And it's also important, so with a tension pneumothorax or any kind of pneumothorax, you may not have circulatory shock because you're not bleeding. So when you have drained all of this blood, you also concurrently need to be resuscitating the patient with a small fluid bolus, and then ultimately you need to be replacing the blood that you're taking out with blood going back in. So next slide is on flail chest. So this is basically if you have 2 or more ribs fractured in 2 or more places, that section of rib is not connected to the rest of the thoracic cage anymore. So as you breathe in, the section of ribs that are just floating about move kind of paradoxically. So one will move in and one will move out. This can then lead to pulmonary contusion and has can have a bad outcome. This may not be apparent early on if if it's subtle or if the patient has other distracting injuries. But usually if you can see it, you would see a section of the rib cage moving not at the same time or at the same way as the rest of the thoracic cavity.
But you should consider this in anybody who's got a major blunt injury to the chest.
Yeah.
Anyone who's received they'll come in and they'll be really clear from looking at them that they're badly injured. Their chest will be all purple from bruises. You'll be able to feel surgical emphysema underneath the skin when you press on it, and the patient will be quite unwell. In this case, again, so you need to manage it with analgesia. The main thing with chest injuries, once you've got the physiological component, once you've got that underway, the main thing is that you manage the analgesia so that you make the patient able to breathe, essentially.
That's going to reduce the risk of, like I said,
problems,
deaths from the third peak. So you appropriately analgesize the patient so that they can take a deep breath in, that they can cough, so that their reflexes of coughing can adequately clear the chest. If somebody's not taking a deep breath in, then pulmonary secretions can harbour at the bases of your lungs, and in a week or 2 or 3 weeks down the line, you can get chest infections that then can obviously lead to poor outcomes.
They have X-ray, do they?
Yeah.
They do.
I've got some X-rays on.
Have they got X-ray then?
Yeah. You guys have access to X-rays, don't you?
Can you take an X-ray quickly of a patient in the hospital, or an ultrasound?
Yes, we can do it.
Yeah. Okay. So these things you can see on X-ray. You can also see on ultrasound. To be honest, ultrasound is the better option in this situation, especially if you have to print out the X-ray and have to look at it in a light box.
There is a caveat to that ultrasound is better if you have somebody trained in using it. So if you're not trained in using the ultrasound and interpreting the images, then it's kind of useless. So it's kind of a what skill mix that you've got there as to what's best to do. So if we move on to the next slide, so the next slide would be on cardiac tamponade. So the classic triad of muffled heart sounds, hypotension, and distended neck veins might be difficult to assess in the context of trauma. You know, if you've got lots of people around, then listening to heart sounds isn't really going to be very accurate. So I would go on the actual clinical scenario and how well the patient is. So if they are unwell and you have gone through all of your other, causes of shock essentially, or reduced cardiac output, then this needs to be considered, especially with kind of any blunt force to the chest. Like Abdul said, fast scan is really, really useful and actually is really, really effective when used well to diagnose this. So you can see any kind of fluid in the pericardial sac with a fast scan.
Yeah, I think the main thing to do from your perspective, because obviously it's not a specialist setting that you've got, is to assume anybody with a penetrating chest injury will have a tamponade. So you've got to suspect it in them. A penetrating chest injury as opposed to a blunt injury, so stab wounds or impalement, things like that. Yeah. So essentially, any injury to the area where the heart is located. So that's starting with the right side of the sternum, all the way to the left side of the chest. You need to suspect there to be injury to the heart, the pericardium. So essentially, the best way to spot it is by using a ultrasound scan, as I said before, and obviously it does take some training to know what you're looking at on the ultrasound, but there's plentiful courses available. So if you do have an ultrasound machine, it's definitely worth everybody having a look and learning what the pictures look like, and also how to actually control the ultrasound scanner.
Okay, so if we move on from problems, we'll move on just to some quick diagnostic studies. So from the next slide, so these are the things that you can do quickly within that first hour. Things like a venous gas, an X-ray, and a fast scan can be done within maybe the first 10 or 15 minutes, depending on your services. So a venous blood gas, what we would be concerned about from a trauma side of things would be what's the pH of the patient, what's their lactate, and what's their hemoglobin doing. So lactate is a really good measure of shock. So if you are hypoperfusing your organs, you're going to be anaerobically respirating, and a byproduct of that is going to be lactate. So if you've got a raised lactate, it could be if you're hypoxic or if you're hypoperfused. and we would follow the trend of a lactate through a patient's kind of journey. So a one-off lactate of 5 or 6 is useful, but then it's to see the next lactate in maybe 10 or 15 minutes time once you've provided that intervention. So if somebody's come in and they've been bleeding and they've got a raised lactate, you've given them blood. On the next blood gas, if their lactate is improved, then that's a marker that you've done something to improve the, you know, the outcome for that patient. So a lot of these things is about looking at the trend as well as just looking at a one-off reading.
And from your guys' point of view, if you don't have obviously a blood gas machine, because many places don't have a blood gas machine. Oh, do they? Yeah. So measuring the lactate and the pH.
Blood gas machine here.
Okay, perfect. Oh, great. Better than mouth, I suppose. So yeah, so the pH and lactate, what you do is you basically repeat. You take multiple samples and you do it every so often to work out what your trend is, if you're getting better or you're getting worse. If your lactate's improving and coming down, then it means you're doing a good job of resuscitating the patient. And if it's going the opposite way, then it means that something you haven't spotted it yet.
Yeah.
HB, on the other hand, HB is unlikely to change straight away. And if it does change straight away, then it means that there's something really bad going on. So if you've got somebody, you know, young male, and he comes in and his HB is 80 or 90, then you know something quite dangerous is happening, because you have to drop your circulating blood quite a lot for you to drop your HB. And so the patient would usually already be showing signs of shock anyway. So you'd already have, you know, the tachycardia, and in late stages he'd be dropping his blood pressure.
So if we just move on, we'll just go through some chest x-rays. So the next slide shows a not fully filmed chest x-ray, but from that film, what is the diagnosis?
Pneumothorax.
Yeah.
Pneumothorax.
What type of pneumothorax?
Tension pneumothorax.
Yeah, so from here you can see that there is an obvious right-sided pneumothorax, but the main thing is that the trachea and the whole of the mediastinum has been shifted across to the left. So this patient should never really have had a chest x-ray, because this should have been apparent on clinical findings. So if you have a chest x-ray that looks like this, you need to do something about it pretty quickly, because the patient has already got to a point where they're tensioning, and as we know, tension pneumothorax is one of the signs and one of the causes of cardiac arrest. So if you see a patient with this, do something about it very, very quickly.
So like I said before, you be brave with the scalpel and just go straight in. If the patient's like this, then clinically looking at him, he's going to be struggling. He's going to be going blue, and he's going to be, you know, on the verge of death. So in this case, you know, quick action is really important. Anyone who, you know, you grab your scalpel, grab your forceps, and just go straight in and make that hole, and push your finger in, and you know, get the air out as quickly as possible.
So next slide. So the next slide just shows you the answer, tension. So if we now this one. So in the context of trauma, and just concentrating on the left side, what on the patient's left side, what would you diagnose this as what we've just discussed?
Pneumothorax. Left-sided pneumothorax.
Yeah. You can see that the left side of the patient's lung is essentially more pacified, so it's whiter, and in the context of trauma, this has got to be blood. And again, you can see a fluid level kind of midway up the chest, to suggest that it's liquid rather than a consolidation.
Yeah, so this is a difficult one, because when you take the x-ray, it's unlikely that your patient's going to be able to sit up if he's been injured and it's caused this. So this is an X-ray of somebody who's quite sat up, because the blood follows gravity and comes to the bottom of the chest. So this person sat up because there's a fluid level. If the patient's lying down, if you imagine how the blood's going to be, the blood's going to fill the back of the chest, because the back of the chest is going to be at the bottom. So the image that will give you is, it will give you more of a completely opacified chest. So you'll be looking at the chest and you'll see a complete whiteout of one side if the patient's flat. And obviously, if the patient's able to sit up and you took this X-ray, it will look like this. So this particular patient, if you were to lay him flat, you'd be able to see that one side would go complete whiteout. And obviously, this patient also needs a chest drain quite urgently, and the location of the bleed needs to be found out quite quickly.
So next slide. Okay, next. Okay, so this might be a little bit more difficult for you to see from so far away, but in the left side of left chest, there's some abnormality.
Just side उसका front the side.
Any taken?
Fractured ribs, we can see on left side.
You can probably see on the computer screen a little bit easier that there are left-sided rib fractures.
The fractures in our left side.
Yeah.
So it's really important to remember that although X-ray is probably the most that you have in this situation, it's really difficult to see rib fractures on an X-ray, because you can mainly only see the posterior ribs. So in this particular case, obviously there's fractures on the left-sided posterior ribs, but you wouldn't be able to accurately count them or check exactly what's going on. So the second that you see an abnormality like that, it's better to send the patient. Yeah, you need to send the patient somewhere where they'll get definitive treatment, or that they have a CT scanner, because a CT scan is really the best option for looking into the chest. Obviously, if you guys are quite far out in Kashmir, then it's going to be difficult. So you might want to just treat the patient as per the pain, rather than thinking, oh, he's got rib fractures, think, oh, he's got pain and cannot breathe, and treat the pain, because realistically you're not going to be able to fix the rib fractures in that situation.
We don't routinely here fix rib fractures, so it all obviously depends on the patient, if they've got a flail, but in patients that have multiple rib fractures that are adequately managed with analgesia, we really very rarely fix them. They might go to the trauma unit and have an epidural to help with the pain, but that's really the most that they would get. We very rarely take patients to surgery for rib fixation. So like Abdul said, the best case from your end is to treat this patient as if they have a rib fracture, if they clinically have a rib fracture, or if you can see fractures on the X-ray, give them appropriate analgesia, make sure that they can take a deep breath, make sure that they can cough, make sure that they're not in so much pain that they're not adequately ventilating their lungs, and then just give them really good follow-up advice. And any concerns, any signs of infection, so fever, temperature, brown or yellow sputum, then they need to see seek medical attention.
Yeah, I mean, obviously, just knowing the reality, the reality on the ground is that, you just tell the patient, here's lots of painkillers, take the painkillers until you're able to breathe, and if you notice that you're getting a chest infection, you need to come back for antibiotics. That's essentially, realistically, your scope of practice over there.
So if we skip the next couple of slides, because I don't think you'll be able to see it on the chest X-ray, but that just showed a flail segment in the right lung. So there's two ribs that are fractured in more than two places, but you'll probably be able to see that better. So next slide is just a brief overview about when you would want to do a CT, predominantly for a CT head. So like Abba said, we're quite lucky here that we have the access to a CT scan, and most of our patients will get a full trauma series, so they'll get a CT head to pelvis. But these are just some what I would call red flag symptoms for patients needing a CT head in the context of a head injury. Can you guys see that okay?
Yes.
Yeah.
Yeah. So this is a obviously this is assuming that you've got the resources to be able to do a CT. But I guess for you guys, these indications would actually more likely be signs that there could be something going on in the head. So this is after a head injury. Now, essentially, if the patient's had a head injury and they're confused, or they're less conscious, they've got a reduced consciousness level, then you can go on to suspecting that there's an injury in the head. So ATLS, if you guys have you guys are going to be doing that, then you'd want to carry out the scan if any of those criteria are met, the high risk criteria. For the purposes of reality, if the patient presents to you and he's got a head injury, a clear head injury, and he's got signs of a skull fracture, then you should probably send the patient off to a centre where they're able to deal with head injuries properly. It is an emergency, and especially in the older population, the patients are at a very high risk of developing an intracranial bleed, and then it could, whether it's on the day or after a few days, the patient can deteriorate and they can die from intracranial bleed. So the take-home message in a low equipment setting is that if the patient has the high risk criteria, they've been vomiting multiple times since their head injury, or they've got suspected open or depressed skull fracture, that would be a sign with the battle signs. You get the panda eyes, you can have the CSF leak from the nose and the ears. Then for you would mean to send this patient off somewhere where they can be investigated for a head injury that is causing an intracranial bleed.
So, Ahmed, are there staff at Muzaffarabad? So how frequently do you do CT scans for head injury?
Very frequently. Like it's a basic test nowadays in Muzaffarabad. Same as you suggest.
So is it available easily? People have access to it.
Yeah.
You have access to it.
Muzaffarabad is available, although on the cost, but it's available easily.
Okay. Do you use any particular criteria, or is it just a clinical judgment?
Actually, this vomiting or signs of meningeal irritation or low GCS, these are the three signs we use this. ENT bleed. Yeah, ENT bleed.
Okay.
Yeah, I mean, obviously over there the cost is going to be important as well, and over here, I guess, because the culture is so different over here, the doctors are scared of being sued by the patients. So essentially, lots and lots and lots of people get a head scan when probably in reality they wouldn't need one. But obviously over there, where you guys are the dictation is it's different. I guess the rate of scanning will be a lot different to what we have over here.
Over there, the patients don't sue; they just the relatives come and stone the hospital.
I'll take the stoning over the suing.
That's the way of quick justice.
They break the hospital windows.
Can you stone
Yeah.
And they won't mess with us.
That's great.
Okay, so we'll move on to the so that's moving away from the primary survey. So now that we've done the primary survey in 5 minutes, maybe 10 minutes with interventions, we've put a chest drain in, and we've given the patient some fluid or some blood, and they're now stable. So after the primary survey, we go through the secondary survey. So this is basically a head to toe examination. You also look at the back, which you haven't done. You take a history of what's been going on with the patient, what happened, and then you reassess everything. So you reassess the examination and you reassess the patient's observations. So if we go through to the next slide, this is quite good mnemonic to use in a trauma. You don't forget anything that's important. So next slide. Yeah, so you can use what we call the ample history. So A-M-P-L-E. So A would be allergies. M would be what medication does the patient take? You know, are they anticoagulated? Do they take immunosuppressants? P would be the past medical history. So any previous, I don't know, bleeds on the brain or aneurysms, everything's important. But certain things are more important in the context of trauma. L would be the last meal. So if you need to take them to theatre, you obviously need to know if they're starved or not, more from an anaesthetics point of view. And then E would be events or the environment relating to the injury. So they may or may not remember this, and it certainly depends on what the actual injury was.
Yeah. So the reason that we have this, this order is because this is the order of things that are most important. So if the patient goes unconscious at any point, you need to get the most important thing to know is that the patient's allergies, and then what medication they're on, and then their past medical history. So it's basically in order of importance what the patient has to tell you first, that you need to know.
Okay. Next, so this is just going through the secondary survey. So starting from the top, so examine the face, so look around the entire head, around the scalp, look in the eyes, check their visual acuity, can they still read, what's their pupils, what are they doing, and have they still got normal eye movements or have they got any kind of ocular entrapment. Palpate all the bony structures of the face, that's also really important. You can pick up facial fractures again on facial bone x-rays, and also look in the mouth as well. Have they got any foreign body kind of within the mouth? Have they got any burns? Have they got any kind of bruising, or have they lost any teeth? Have they swallowed or inhaled a tooth? That's also really important. Going on to C-spine, so if you haven't cleared a patient's neck yet, keep them immobilized. Palpate down the midline of the neck, palpate all the soft tissues. Can you feel any surgical emphysema? Palpate that the trachea is still central, and make sure you feel and listen to the carotid arteries to see if you can hear any bruits, could be sign of some vascular injury. Do you guys use the Canadian C-spine rules out there to clear a patient's neck, or is it just kind of clinical judgment?
Just a clinical judgment, not the rules.
Okay, do you know what the Canadian C-spine rules are?
No, we don't worry about it.
No? Okay, so it might be something useful to look up, but it's basically how you can clear a neck clinically. So have they got any tenderness? What's their range of movement? And it just helps you decide if you need to proceed for an x-ray or not. So in kind of simple traumas, that's what we would use for the C-spine.
Canadian C-spine rule is a really good way for you to reassure yourself that, you know, you don't need to be too worried about the patient's spine, because obviously, you know, you have a patient, you know, if they're complaining a lot, you know, and you find yourself concerned, you know, has this patient got a spinal fracture or not? You can use this. So essentially, have there been any of the following high risk factors? And the high risk factors are sort of, you know, high energy impact, well, there it is. Are they quite old, or have they got any tingling in their fingers? Essentially, if yes, they probably need an X-ray. If not, then are there any low risk factors? So, has the patient been able to walk at any time since the injury happened? So, if the patient has, since the injury has happened, if the patient has been moving about, then they probably don't need an X-ray.
Yeah.
If the patient had immediate onset neck pain or delayed onset neck pain, so immediate onset neck pain is a reason to do an X-ray, and delayed onset neck pain is a reason to not do an X-ray, because that implies it's more whiplash.
Yeah.
And ask the patient to be very clear about whether the pain is in the midline or on one of the sides. If the pain's in the midline, then they need an X-ray. If the pain is more on one of the sides, then they need then it's more likely to be muscular from the muscles in the neck. Obviously, in the setting where, you know, you've got a, you know, angry or hysterical patient, and, you know, they're demanding an X-ray, if you just use your finger at the back of the neck and make them be very clear and honest about telling you if the pain's in the middle or on the sides, that should be able to help you avoid unnecessarily, you know, X-raying.
Following on from the low risk, if they've got any low risk injuries or mechanisms, so like Abdul said, delayed onset, if they're ambulatory, and if they're mobile, if you have those low risk as a tick yes, you then would ask them to rotate. So look to the left and look to the right. If they can look to the left and the right to 45 degrees, then you don't need to x-ray them. If they can't, then you would still proceed to an x-ray.
Yeah. So anybody who's got a neck fracture, if you've ever seen them, they're very rigid and they're very scared to move their head. You know, they really will not move any further than this, because they can feel like their neck's cracked.
They kind of go like
yeah, it's quite obvious comparing someone with a neck fracture to someone who isn't. So they definitely cannot look 45 degrees left and right.
Sometimes
And
the MSK ones like this.
yeah, and that's a really good way to you know, reassure yourself that the patient does not have a neck injury. And to be honest, having the Canadian cervical spine rules available for you guys as a quick reference would probably be quite useful.
Yeah, and it's universal. It doesn't, you know, the next step would be x-ray, so it's not like it's going to lead you on to doing a CT scan or an MRI. You know, the outcome is something that is always easily available.
Yeah, so it's a low risk, high high yield, high yield option.
So if we go on to the next slide, so this would then move us on to the chest examination. So reassess the anterior chest, and at this point you can look at the back of the chest, so posterior inspection examination, palpate all of the chest including the clavicles, again percuss and auscultate as you did in the primary survey. In the abdomen and the pelvis, again palpate, re-examine, you know, everything, and palpate around the pubic ring. Have they got any bony tenderness? Do they need a pelvic x-ray that you may not have considered in the primary survey? And then the perineum and the rectum. So if somebody's got spinal cord injury, then they're going to probably need a PR. Well, definitely need a PR or a DRE. So that's something. And then in pelvic trauma, you just need to inspect the perineum and all down around there just to make sure that there's no, you know, problems.
Yeah, so the job of the secondary survey is to identify any injuries that you may have missed that are not life-threatening but do need dealing with. So in general, it's quite a musculoskeletal thing. So if you think back to orthopedics, essentially you're doing a big orthopedic exam of your whole body. start. Yeah, and the neurological exam. So you're going to check clavicle. A really easy way to do it is just get one hand and press just along the way clavicle. Does this hurt? Yes or no? And then move all of the joints. Ask the patient if it hurts, and then palpate the joints. Make sure that, there's no fractures going on. Palpate the long bones. A good way to quickly check long bones, like arms and legs. A good way to quickly check the arms and legs is to ask them to lift their legs straight. So anybody with a fracture at any point during his leg cannot lift his leg straight. So it's a quick way to check that the legs doesn't have any long bone fractures. So get them to lift one leg straight, second leg straight, and get them to lift your arms and to lift their arms and squeeze your hands to check their arms as well. And then you just do a quick check all the way down. Move the elbow, move the wrist, check the fingers. Yeah, exactly. And get them to squeeze your hand to check for any hand fractures. So that this is mainly important in people who've fallen or been in a vehicle accident.
Yeah. So like I've said, so you've got the MSK system there as well, and alongside that you can do the neurological exam, so motor and sensory examination as well. Just have they got any occult spinal injury, something that you may have missed. So the next slide, I was hoping to be able to show you a video of a mock trauma call, but I couldn't get it to download. So if we move on now, I've got two cases. So the first case is of a 19-year-old male, a motorcyclist versus car, approximately 100 miles an hour combined speed. He was a single rider.
Oh, yeah. I didn't say 100 miles.
Yeah, I added it.
Oh, okay.
And he's not wearing any safety gear.
Okay, so I sent it a bit less in depth because obviously you guys are not going to have anywhere near the kind of pre-alert that we get with the paramedics. So realistically, what you'll get told, if you get told anything, is someone's had a motorcycle accident. He was the only person on the motorbike, and he's still alive, essentially.
So, next slide.
Okay, so hi Norman.
Hi Norman.
I was there, I'm just because it's just a case.
Okay, so essentially, so quick questions for you guys. In a motorcycle accident, in a young male, what do you guys expect that we might find on the primary survey, starting with A to E? So, yeah, shout it out.
Head injury or C-spine injury, most probably.
Yeah.
Major trauma.
So what do you expect from A point of view?
Primary surgery, you find head injury from motorbikes.
From my
ABC.
Yeah.
Okay.
Disability and hemorrhage.
Bleeding.
So as Amy said earlier, it starts ABC, so circulation. So if there is an obvious bleed, you have to stop it with the pressure, and then ABC at the same time. Circulation, C with airway management.
ABCD.
Yeah, so remember this is a motorcycle, and realistically, he's probably not been wearing a helmet, and he's probably come off it, and he's probably banged his head. So, you can find, catastrophic bleeding from one of the limbs will be very likely, especially if he's
traumatic amputation.
Yeah, especially if there's a traumatic amputation. That would be the obvious first thing to deal with. In terms of the airway, so the main things from a trauma perspective of airway is physical damage to the airway. So someone not wearing a helmet or wearing only a half helmet can hit their chin on the
facial trauma.
Floor. They can have severe facial fractures, which can occlude their airway, neck injuries. So all of those would be reasons to be concerned about the airway. Did you go through surgical airway with them?
No, I don't.
Okay. So one of the things that you do is a surgical airway, which is a cricothyroidotomy, which is where you make an incision and put tube down the patient's trachea. You can find detailed walkthroughs for that on the Royal College of Surgeons. So if you need to look that one up, definitely that's definitely a skill that everyone should know. So that's A. In terms of B, that
if you go to the next slide, we'll show you the primary survey that was found.
So the patient got up and he walked around, and he came in. Oh, there it is. So when you examine his chest, you find that his breathing is shallow and his respiratory rate is high. With your stethoscope, you hear reduced air entry, and it's very painful on the right-hand side.
Yes.
Okay. So, what will you do at this point?
We will stop the bleeding first.
Breathing position, shallow breathing, reduced expansion of very painful right side. Okay. No.
Reducing pressure and
pneumothorax sounds breathless.
So
hormone
acid
क्या? Acid analysis earlier will give the needle and remove that pneumothorax.
Yeah, if you discuss between yourself and one of you just answers it, how you will manage? What will be your intervention at this stage?
So we assess that this one is point B. This is tension pneumothorax or kind of pneumothorax. So we will do the needle thoracotomy. We'll try that one and go for X-ray if possible in the settings.
Yeah, absolutely. Yeah, that's definitely right. And so in this case, the guy's got a pneumothorax or a hemothorax, and it's probably on the right hand side. So clinically finding, you should go with the needle decompression. Now the problem with the needle decompression, has anyone ever done a needle decompression? Put your hands up if you have.
No.
Yeah. Yeah. So if you imagine what you're doing with a needle decompression is you're putting a needle in and you're going through the skin, and then you're going through the pectoralis major, and then you're going through all the different connective tissues, and eventually you're going into the chest cavity. So the first thing is with the needle decompression, a lot of the time you actually get some tissue blocking the needle, which is why usually if you do it, it's actually better to put a syringe on and inflate first to push out any tissue. Also, because you've gone through so many tissues, you're actually very unlikely to actually get to where you want to be. Efficiently, yeah, because it's very difficult to actually get it in the right place unless you've got quite a skinny, a skinny patient essentially. And the bigger the patient, the less likely you are to be successful with doing it. That's why the Royal College of Surgeons in the UK and also the European Trauma Society, they're moving away from doing the needle decompressions and into doing the thoracostomy with the scalpel and making the incision in the mid-axillary line in the fifth intercostal space, because that itself is actually about as fast and it has a 100% success rate, because once you're in the cavity, you can guarantee there will not be any more tension pneumothorax. Does that make sense?
You can also then go on from doing the thoracostomy to putting in a definitive management through the same hole. So you can put in the chest drain through the same hole.
Yeah, because if you've had to decompress it with a needle decompression, then the patient's going to need a chest drain eventually anyway. So the argument is, why bother with the needle, which may or may not work? Just go straight on and do the thoracostomy and insert the chest drain on the spot. It'll be a lot more successful, and that's where practice is moving towards in Europe at the moment. Do you agree, Norman?
So you're suggesting that
don't shy away.
We should go for this.
Yes, Ahmed, go ahead.
You broke.
I mean, you people are suggesting that thinking about needle thoracostomy is not the way right now. It's not recommended. Like, although we are doing it here in Pakistan, but we should move towards that, putting the chest drain in the same incision.
Yeah, so like I think one of the main things is when you're doing a needle decompression, if you think about the size of the needle that you can put in, and like Abdul said, the depth, you may only get something that's 2 or 3 millimeters wide, the actual lumen of the needle. So unless you're draining air, which is going to take a little while to come out through a small needle, if you can make a finger width incision into the side of the chest, you're going to get a lot better outcome a lot faster, and then your definitive management of using the chest drain, you've basically already done half of the job.
Yeah. And it's not dangerous.
If you go in that triangle of safety,
yeah.
The only thing to remember is the neurovascular bundle of the ribs runs underneath the rib. So if you are putting in a chest drain, you want to try and go as close to the top border of the rib as you can. So if this is 2 ribs here, the neurovascular bundle goes underneath the rib. Okay, so when you're putting anything in or making an incision, you want to try and go over the top of the rib. So you avoid hitting this bundle, you avoid any nerve damage or any vascular injury. So roll over the rib.
Yeah, so assuming that you avoid the neurovascular bundle, it's very safe and very easy to fix as well. It's a very simple case of just putting in a horizontal mattress suture, and then you can close it with a silk suture very easily with your hand, if it turns out that you didn't need it, essentially.
So if we move on to the next slide.
Yeah, next slide's good.
So this is what we basically just said. We've gone through.
Okay. So if you guys don't have blood to give as a transfusion, then it's probably only a good idea to give crystalloid in the in the absolute last resort of a patient being in shock. Did you go through sort of crystalloid versus blood?
No.
Okay.
I just said blood was better.
Yeah. So fine. So obviously, in the interest of time, we'll abbreviate it. But obviously, the fluid, IV fluid, that's crystalloid or colloid, has 0 oxygen carrying capacity and 0 clotting capacity. So if you give it unnecessarily, you are just diluting the patient's blood clotting factors, and you're washing away the clots that they formed. So the first clot that you form is the strongest clot, and after that, everyone after one that is weaker. So if you give fluid unnecessarily, you'll actually increase the chances of killing the patient. So only give the fluid if the patient is shocked to the point that they, they're in extremis. Okay. So fine. Go on next.
So the next couple of slides we can kind of skip through because we've already talked about them.
Yeah.
So
a few words about the analgesia. A few words about the analgesia.
Yeah. So a few words about analgesia. So analgesia is a very common thing to overlook in the emergency department because the patient's in a lot of pain, and as the doctors, we're very focused on treating the physiological damage to the patient. But actually, pain itself causes a physiological response, which causes peripheral vasoconstriction, and it causes a lot of physiological things which we don't like. That they'll make the patient worse. So actually treating the patient's pain is a very important part of successfully managing the trauma. Especially in these injuries where the patients are in a lot of pain, it's really important you adequately drug the patient to the point where they're comfortable, because this will make everyone's life a lot easier. It'll make the patient's life easier. It'll make your life easier because number one, you're not dealing with a screaming patient, and number two, because the patient's physiologically more compliant with what you're trying to get them to do. So you do really need to consider using, especially IV morphine, excellent, and ketamine. Yeah, ketamine's another vital one which you guys will have.
What drugs have you got them out there?
The issue is that in our country, in Pakistan, we don't have IV morphine available so readily. We have that for chest pain or for cancers, but not in the trauma settings.
Okay.
That's the availability and with the use. So we pethidine or morphine is not the option in acute settings for us.
Okay.
So do you recommend something else instead of this?
Okay.
We have,
the second line.
tramadol. They have tramadol there, and nalbuphine there. Nalbuphine. And for this hospital, if I can add here, we are asking the government permission to give us fentanyl and morphine. So over there, you have to make a case and apply it to the drugs department and the Ministry of Health. And you have to register your hospital to get it. So we are in the process of doing that. So they will get morphine over there, at least at the MDMI.
The problem with things like tramadol is that they're all oral tablets. So we like to use things intravenously in the emergency setting in case we need to keep a patient ill by mouth, or they haven't, if they've not got a secure airway and they're anaesthetized and intubated, then you really need to be able to give things intravenously or IM. So I guess it's whatever you have access to.
Yeah, essentially,
just do.
Yeah, essentially just give whatever makes the patient comfortable that you have with you, even if it's only paracetamol. Start with paracetamol, and then if you have literally whatever you have, just give it. Essentially, make the patient compliant, make the patient comfortable.
Yeah.
So this is a slide on the chest drain insertion, just as a quick 9-step procedure. It's very quick. You can do the whole thing in about 30 seconds.
Once you've got the equipment.
Once you've got the equipment, all you need is a scalpel and a divider.
A clamp.
Yeah, so like a needle holder or divider is easy to blunt dissect. The pneumothoracentesis, as I said before, it's not as good. Yeah, go on.
Okay, so we did a secondary survey, but in the interest of time, we've got one final case if you want to go through that.
You put open fractures on.
Go ahead.
Yeah, but we don't have time.
Okay.
So if we skip through to case B, so we can send you the slides so you can look through the secondary survey. So this is a 23-year-old, touched a railway line, now has severe burns and has a reduced GCS.
Yeah, so the reason I put this one on is because when I was in India and in Bangladesh, I found out that it's really common to get these electrical injuries. It was so widespread in the center I was in the burns unit. There were literally dozens of people who'd touched railway lines or electric shocks. So I thought it'd be a good one because it's usually quite overlooked, especially when it comes to teaching. But essentially, an electric shock is a burn, and you treat it as a trauma with the added physiological changes that an electric shock can cause. So if you just go to the next slide. Hang on. Yeah, so what could we find in a primary survey on an electric shock?
CABC, catastrophic hemorrhage, ribs, increased circulation, disability, and mostly airway को touch किया, railway को touch किया, तो उसमें कौन सा लगने सारी में people have a chance. जिससे आपने बेटी का कार पकड़ लिया तो ये हमें चांस का कॉल कर देंगे
उसने मेंशन किया ना कि उसको बर्न्स आए हैं और उसका डिस्ट्रेस रिड्यूस्ड, ये दो चीजें मेंशन की हैं।
सो क्या होगा
Why say and
so we'll find burn injuries most probably and we will look
Yeah,
for facial injuries and compromised airway.
and biggest concern would be exhaled injury.
So burn, airway, and what was the third thing, Ahmed?
So GCS is also reduced, so might be history of fall like that, trauma settings like that.
Yeah.
Kind of vision.
Thrown away by a high-powered cable.
Yeah. So in a high-powered cable, the other thing to remember is the
I'm not
cardiovascular.
sure about the knowledge or not, but other things will get.
Yeah. So so Amy skipped the slides. She didn't put it in, but I did make a slide about electric injuries. So in Asia, it's one of the leading causes of death in children, I think, is electric shock. Am I right?
Yeah.
Yeah.
That's one of the.
Yeah. So an electric shock follows an entry point and an exit point. The entry point is usually where the person has come into contact with a cable. So it's most often it's a person's hands because they've been on top of a train and they've held onto a cable, or they're a kid and they've held onto an overlying cable, or it's on the head where they've been hit by a hanging cable. And you can have two different types of current. There's alternating current and direct current. Now a direct current, in both cases, they follow an entry wound and there'll be an exit wound on the most grounded part of the patient's body. So usually it's in the feet. So a lot of times you can.
Abdul, I want to say something.
Say again?
Yeah, I do want to say something. Yeah, I see Amy King on my screen, but you are not Amy King talking, are you? It's,
oh no.
Hello.
I'm not Amy
the
King.
Speaker, Numan, the gentleman who is giving the talk. May I know his name, please?
Yeah.
Sorry, Mr. Iftikhar, Amy King is one of our registrars here at Queen's, and
I can see him now. I can see him now. I just want to interact here, and I say, look, in Kashmir, the electrical injury is very common, extremely common. What happens is that guys actually want to steal electricity from the main line, and they climb up the pole and they hook. And once they try to hook it, sometimes they get electrocuted. And so there are two sorts of injuries they get. One is the injury which you're describing, entry and exit, and the other one is they fall on their back and they get a spinal fracture and chest injury. So it's very common, and they also get that problem when they are stealing walnuts. The walnut tree has got a very supple. They go up to the tree and try to pick the walnuts, and they fall on their back. So they get chest trauma and the spinal trauma that way. It's a very common problem in that part of the world.
Oh wow, yeah. So sorry, Dr. Iftikhar. My name's Abdul Latif. I'm one of the doctors in Nottingham with working with Amy and Norman.
Yeah, I work very close to you as well. I work at Royal Derby Hospital, not far from you.
All right.
We're neighbours.
Yeah, we are neighbours. Long time ago, I was senior registrar in your department of surgery. I did my DM from there as well. All my research was done in that department. Yeah.
Oh, wow.
So I know your hospital very well. Yeah.
Sure.
Mr. Iftikhar, I think you just joined a short while ago, but I must say both Amy and Abdullah have been exceptionally good over the last couple of hours. The amount of resource,
I joined in.
the amount of resource they have collected.
Sorry
And
to interrupt.
yeah.
And I'd like to say that Narman gave me 2 days notice.
That's 2 days more than what he gives us.
No, they've actually. I just wanted to say that, especially for the MDMI staff, the ATLS manual they are taking you through. These are the courses. I'm sure Mr. Iftikhar and Dr. Javed and Dr. Zahid and Dr. Rahim will second me on it. These courses are so oversubscribed in this part of the world that you have to wait for months before you can actually get onto one course, and you get exactly the same teaching which Amy and Abdullah have been doing over the last few hours. And it is just a blessing which MDMI should utilize as much as they can. And I'm really grateful to both Amy and Abdullah. We're really grateful to you. We're really grateful to you.
And they have concised 2 days work in 2 hours beautifully. I think it was an excellent presentation, and it was also a refresher for us as well.
Well, I've learned a lot
shut
again.
up now and let them carry on. Just on the note that when I went for my ATLS, the first section of the MCQs I failed miserably, and I had to work very hard for the next good 2 days, 3 days to actually pass the test at the end. Yeah.
One thing that you can get onto, so ATLS is subscribed, but the European trauma course.
I didn't do it in Pakistan.
Oh.
Yeah.
The ATLS, the key is to read it first. The book, which I've thought that I knew it all, and there's no need to read that book first before I go on the course. That was the biggest mistake one has ever done in life. So they have to read. Reading is a must to start with, and then come on the course, and then learn from it, and then you will pass. Yeah.
Yeah.
Thank you. I will shut up now. Thanks.
Thanks, Mr. Iftikhar. Okay, so the case with the electrocution, like I said, is the entry wound and the exit wound. So within AC and DC, the difference is really with the kind of arrhythmia that you can get. So if you remember your heart, obviously it's governed by the electric current. So in an AC shock, essentially, most often kind of presentation is asystole. So the patient will be in complete asystole and cardiac arrest. In this case, it's obviously really bad, but you follow the usual algorithm that you'd follow in terms of doing CPR and doing CPR, and you give adrenaline and amiodarone, and then eventually, when you get a shockable rhythm, then you carry out the shock, the defibrillation. With AC current, you're more likely to end up in ventricular fibrillation or ventricular tachycardia. So this is because obviously the alternating current goes in both directions. It goes forwards and then backwards, and it can, as opposed to stopping your heart completely, it will cause an aberrant pathway conduction in the heart, and so set the heart in a disfigured sort of conduction loop. In that case, again, you follow the normal ALS guidelines, which is, do the CPR, continue, and then give the shock when advised, and then keep going with adrenaline, etc. The rest of the trauma will continue in the same way as the rest of the ATLS trauma that we're talking about. And obviously, a lot of the time, this is coupled with the patient having fallen from a height, so there'll be spinal injuries, lower limb injuries, other injuries accompanying it. But in this case, it's a pure burn that we're talking about. So in this case, the patient's breathing. You've assessed his airway, and the patient's airway is clear. His breathing is shallow, and he's saturating 92% on air without any oxygen, and his respiratory rate is 30. He has got reduced expansion on both sides of his chest. Can anyone think why that might be? Yeah, just
something
shout it out.
You might.
Chemo mostly tension disorder. Open no, reduce expansion bilaterally.
Anyone
The
got any
thing is,
idea?
just use expansion bilaterally.
So think in the context of the mechanism and the trauma, what could have happened to the patient's chest to have given them physiology both sides? So what is the what goes around your chest basically?
Might be fractured ribs,
Diaphragmatic paralysis,
paralysis of diaphragm.
C3-5 injury.
Okay, so in the context of burns, why would there be reduced expansion on both sides?
Burn maybe. Burn? Diaphragm injury. Burn to setting सीखना जरूरी है.
So if a patient has burns on their hands, or
Wait, hang on. So just think about it quickly. Think about when you burn, when you get burned flesh. What happens to the flesh?
What happens to the flesh? Cool.
Think about the last time you had a kebab or a kufta. What happened to it?
what was it? Was it alive?
Have you come across burns which is circumferential? Does that rings the bell? Circumferential burns?
Yes.
I think that's not something which. So yeah, Amy Abdul, if you explain circumferential burn.
Yeah, so essentially what happens is, if you think of your kebab or your kufta, when you've got the meat and then you burn it, essentially it dries out and
yes,
it goes crispy. Yeah?
Yeah.
So the same thing happens to human flesh, identical. If you get a burn on your skin, so say in your arm, and the burn goes full thickness, the skin loses its water. The cells in the skin, the water comes out of them, it evaporates, and so you're left with dry, crispy skin.
Dead skin.
Dead skin. Now, if you get burns to your chest, and the burns are all the way around your chest, or the majority of your chest, your skin, which is normally able to stretch, is unable to stretch, and so you're unable to breathe because your skin will
like
not.
cling film around your chest, basically.
Yeah, your chest has gone crispy, and so you can't breathe because your chest just won't expand because the skin is too crispy and it's dead. Does that make sense? Yeah.
That's very nicely explained. They're fasting, and when you said kebab, they were thinking about food.
I know, I'm fasting as well. That's why I thought of it.
You can tell what's on his mind.
Oh, that's not. I made a mistake. So that's really the most important thing when it comes to a burn. You can have burns which go all the way around a part of your body, and when they do that, it will constrict very tightly, and everything that's on the opposite side gets swollen up. The same thing happens on your chest. Your chest will get constricted, and you can't breathe because the skin is too tight. So in this case, what you may need to do is you need to carry out a surgical procedure, which is where you carry out a cut in the dry skin, and the term for the dead skin from a burn is called ishkar. and it's essentially, just think of it as scarred tissue, so dead tissue, and the tissue has lost all of its function. So it's lost its ability to be waterproof. It's lost its ability to protect your body from infection, and it's lost its ability to expand. So it no longer carries out the job that skin has to carry out, and it loses the ability to hold heat in.
And it loses water. Oh.
Yeah. So because of that, we'll get onto it in a little while about what you do for that. But that's the physiology and explanation behind why someone with a burn to their chest may have reduced expansion. So they may have a pneumothorax because they've just fallen, but in this particular case that we're talking about, it's because of the burn. But this doesn't mean that you say, oh, there's no pneumothorax, don't worry about it.
So carry on, next slide.
Yep. So hang on, wait.
Oh.
So you'll also notice that the patient has a blood pressure of 85/40 when you check his blood pressure, and the heart rate is 120. Okay, this implies the patient is shocked, caused by a loss of circulatory volume. Now, if you remember what I just said, the skin's one of its jobs is to be waterproof. Now, in a burn, so it's waterproof, so it stops water coming in and it stops water getting out as well. So once your skin has lost that ability, and the tissue has profuse edema. So if you think of the swelling that is occurring, water is leaking out. So your body loses a huge amount of its circulatory volume from the burnt tissue. So this causes the patient to go into shock, despite not actually bleeding from anywhere. Does that make sense?
Yeah.
Okay. So the patient's GCS is reduced in this case. His GCS is 9 because he's in shock and he obviously had this massive injury. So we'll get onto that as well. On E, when we examine everything else, obviously there's burns. Burns is the most clear thing. So let's go to the next slide where we'll talk about the immediate management. Next slide. Okay, cool. Okay, so we're talking about the airway. Now, in a patient like this, do you have, if you've got anesthetics over there, you've got someone who knows how to intubate the patient and make the make the patient intubated and secure the airway. That is your priority. Also, in other kinds of burns, for example, smoke inhalations, house fires, gas explosions, and that sort of thing, you can have searing and burning of the mucosa of the mouth and airway. What this will cause is swelling and edema, and the edema can go from all of the mucosal surfaces. So that starts with your lips and goes all the way down into your lungs. This is really dangerous because the swelling causes closing of the airway, and it also causes severe respiratory problems. So if the patient is this badly burnt, you need to get them to your local burns unit straight away. And I think in Asia, the majority of areas have a specialized burn hospital. That was definitely the case in Bangladesh and India where I went to. So it may be the case over there. Do you guys have a burns unit nearby?
No.
I think the closest one is about 5 to 6 hours journey.
Okay, fine.
Which is Karia.
Rawalpindi has got one as well. And I think it is.
Never have to go across. Okay. So this is an example of what I mean by entry and exit wounds. So if you look at the top left diagram, that shows the typically what's going on. So you've got the patient, who's been holding onto electric wires. The entry wounds, just to go into a bit of the electrics behind it. So the skin has a high resistance. Okay, so when you have something with high resistance, it generates a lot of heat as part of the conduction pathway. So when the electricity goes into the skin, it converts a lot of the energy into heat. So you get necrotization of the tissue, as you can see in the top right diagram. And because of the huge amount of heat that's generated, the tendons and all of the soft tissues in the forearm as well, they'll all contract. So you end up with this contracture looking picture over there. This is very, very painful. The burn itself will be, so obviously, you've got the definitions of different types of burns. You've got partial thickness, superficial, and full thickness. So your partial and superficial burns are very painful, but your full thickness burns have gone all the way down to the nerve ending, so they're not painful at all. So when it comes to burns, the more painful it is, the less injured the damage is. So you
less serious.
Yeah, the less serious. So if you've got a patient who's got that hand on the top right, and he's not in any pain over there, then you need to be very, very concerned, because that means that the
more damage done to the underlying tissue.
Exactly. So if you look at the bottom right, you'll see an exit wound. So similar to how gunshots have entry and exit, the electricity also has an entry and exit. It's also demonstrated in the top left. The exit wound essentially is just exploded out like that because the current has gone down the nerves, because the current travels down nerves, because they have the best electrical conductivity in your body. So it travels down your nerve and it shoots straight out the bottom of your foot into the ground. Depending on what part of the patient's body is grounded or has the connection to the ground, it will shoot out that way. The electricity takes the path of least impedance and shortest path down. So you get these horrific injuries, which look terrible on the outside, but actually on the inside they're a lot worse, because the heat that's traveled all the way down has caused damage all along its path. So that foot actually will have extremely severe internal injuries, and I think in this particular image, that patient's leg needed amputated because of how severe the burn was. And Dr. Rashid has said that obviously if you guys have any questions, you can type them on the side as well. That might be a quick way for us to see it. So with those burns, we'll talk about the patient in the scenario. So if you go to the next slide, yeah, burn calculator. Okay, so this particular patient had burns on his left arm, left trunk, on his trunk, anteriorly and posteriorly. That's what I mean by circumferential, so it's gone around the front and the back. And you need to estimate the patient's total body surface area that is damaged by the burn. So do any of you know the technique for calculating the body surface area covered in burns?
So 18% for anterior left side and 18% for posterior side, and then 18 and 18 again for other limb, and 9% for the back, 9% for the abdomen, 9% for the chest, and both arms are 9%, 3%, 1 by 3% palm and feet.
Yeah, because they actually learn medicine in other countries, not like us. Okay, so essentially, yeah, so what you said is absolutely right. Over here, in fact, you guys can have it as well on your phone. We've got an app called Mersey Burns, which you just draw the burns on. Mersey, M-E. In fact, we'll write it on the side.
Yeah, just type it here.
Okay. So you simply select full thickness or partial thickness, and then you can turn the patient around and you draw the burn on him, and then you can, yeah, go on. And then it can help you calculate the amount of fluid that you need. It has it right there. Oops, alarm. And it will tell you how much fluid to give from that. So the reason we're calculating the total burnt surface area is to calculate the fluid requirements.
If you go to the next slide. You can obviously find body diagrams online to help calculate, but the app is a lot better. Yeah, so
I would advise you use the app because
it
makes everything so much quicker and easier.
Yeah. Next slide will show the IV fluid requirements using what we use as the Parkland formula.
Yeah. So the formula for calculating the amount of fluid, if you check the next slide, is called the Parkland formula, and that's a very useful. Back one. Wait, back one. It's a very useful formula to check and tell you how much water you need to, how much fluid you need to give the patient over the next 24 hours. So in order to calculate it, the app actually does it for you. You simply you put the patient's weight and age and the time of injury in it, and it'll tell you how much fluid to give and when. But essentially, you want to resuscitate this patient following the formula. So if you look at what it says 2 to 4 milliliters times the percentage of body area burnt multiplied by the body weight in kilograms. So start with 4, and then you multiply by the percentage of the body surface area burnt. So in this case, the patient had 80% burns, and then multiply it by the body weight in kilograms, and say 75, which gives you 24,000 milliliters. Okay, so you need to give the patient 24 liters. Okay, a lot. Yeah, so it can be a huge amount of fluid that you need to give this patient because they're losing it out of their skin. So they are incredibly shocked. These patients have an immense fluid requirement.
And the higher proportion of area body weight, area skin, but that is burnt, the higher proportion of fluid that you're going to be losing because of the less resistance of the skin to maintain fluid within the cells.
Yeah. So in this patient, he is severely burned. He had 80% burns. It's very unlikely you'll get a patient with 80% burns who's still alive, to be honest. But we're just using it for the sake of this scenario. So this means that 24 liters is how much fluid the patient will need over 24 hours. So with this formula, you give half of the total in the first 8 hours and half in the next 16 hours. Okay? So you're giving half of it, so 12 liters in the first 8 hours, and you're giving the next half, so the next 12 liters, over the next 16 hours to give a total of 24 liters over 24 hours. Does that make sense?
Yeah.
Okay. So the best way to measure the patient's fluid status is by checking their urine output. So every single one of these burnt patients, whenever you get a burnt patient, you need to give them a urinary catheter. Okay, and you want to aim to titrate so they're giving at least 2 mils per kilogram per hour.
Okay, so I have a question. This will be applicable for 15% or 20% partial thickness or full thickness burns, or every kind of burn. This formula would be enough.
It's all kinds of burns, so whether it's partial or full thickness. So either way, because you still get the edema, you still get the swelling, and you still get the loss of fluid, even if it's a partial thickness burn. Especially the deep dermal ones, you can get a lot of blistering, and the blisters will burst, and they're full of fluid, and the fluid all comes out. So in terms of the immediate management of this patient who's arrived in front of you and he's burnt, the best option that you can do is to wrap the patient in cling film. So cling film is very widely available, and it's sterile as well. So what you do is you wrap the patient loosely in cling film over the arms and over the body as well.
Don't do it tight.
Okay, don't do it tight, you do it loosely because the patient's going to swell up. So you want to give them lots of space. The point is that you're going to keep the fluid in. And you can put plastic bags over the patient's hands, okay? But don't use the burns creams that a lot of places advertise because you're trying to correct the skin's physiological job, which is to be waterproof, rather than just give an ointment for the burn. Okay, these patients also need a lot of analgesia.
Yeah, I was going to say lots of
analgesia. Okay, so these are going to be like your highest requirements.
The strongest that you've got, give it.
Yeah, whatever you've got, you give. Okay, because these patients are in agony and it's excruciating. And to be honest, for everybody involved, the patient and all the staff, it's horrifying. Yeah, the smell of burnt skin stays in your nose for the next couple of days.
Oh, let's move on.
Okay. Okay, so the next slide talks about the procedure that we talked about, which is the ischorotomy. So if you remember, we called the ischar the dead skin. Essentially, you're making a cut in the skin, and you go all the way down to the layer where it starts to bleed. Okay, so it's a very deep cuts that need to be made, and you're essentially taking out strips so that the patient can so that you're basically creating an area that's stretchy. Okay. You rarely need to do this immediately, but because but what we say is if you can get the patient to a burns unit within 6 hours, then you don't need to do it. If your nearest burns unit is over 6 hours away, then you might need to start thinking about doing this in your hospital. The issue is that these wounds will bleed a lot. Okay, they're going to bleed a lot because you're going to be cutting all the way down to the vascular layer. So because of that, you need to be able to transfuse and replace the fluid lost, the blood lost in these patients. Okay. Does anyone have any questions about the ischorotomy if they're not quite sure about it? Obviously, we're not going to say how to do it. You can go and go on the Royal College of Surgeons to find instructions. They've got very good courses, online courses on all of these procedures. So does anyone have any questions on the ischorotomy and why we do it? No? Okay, cool. So the other interventions, like I said earlier, you got the soot and the burning in the mouth, you got the erythema of the airways. So these patients, before you send them along, you should give them an NG tube and a catheter. Okay, and as it says, analgesia in capitals, huge analgesic requirement for these patients.
Just skip that slide.
Okay.
So the next slide.
Next slide
basically says get them to.
Yeah.
Yeah, that's fine.
Yeah. So this is just sort of the definitive management. You're not going to be able to manage these kinds of burns alone. You need it to be in a burns unit. So you need to get them on the phone immediately. Basically, as soon as possible, just get a burns specialist on the phone. You're speaking to them, and you're you're getting specialist advice tailored to the patient that you're dealing with. Obviously, confounding all of this, the patient may have multiple injuries, they may have comorbidities, they may have other severe medical problems. So what we've spoken about, to be honest, is a best case scenario where it's just an isolated burn. But,
with 80%.
Yeah, but this is very rarely the case. So you need to not forget your secondary survey to check for other injuries. You can still have open fractures, which are internal injuries. You can have abdominal injuries still. In getting the patient ready for transfer, I put a bit about that because that's really what you guys are going to be doing. You need to make sure all the burns are covered, you've got adequate analgesia, you've got enough fluids for the patient, and you're keeping the patient warm. The patient will get cold very, very quickly because A, he's lost his skin, B, he's losing lots of fluid, and the fluid carries heat with it, and C, because you're giving him lots of cold fluid, most likely. So because of all of these things, the patient will essentially drop their body temperature very quickly, and you need to maintain their temperature by putting warming blankets and heating blankets if you have them. Okay?
So the final slide is just a summary of burns.
Yeah. So
distressing for everybody. Don't get distracted.
Yeah, just remember the burn is distressing for everyone, okay? And you need to really maintain calm be calm when you're doing it. You know, you can get kids that have been in a house fire. It's very emotional. You know, you have screaming family members. It's not an easy situation to be dealing with at all. And you really, this is like the high level, along the line, along with, you know, mass casualty incidents. This is the kind of thing where you really need to be able to focus, calm, and do your calculations and treat it as objectively as you can. Remember, the burns themselves can be distracting injuries. So if a patient has a deep burn on his arm, which is causing him a lot of pain, not a full thickness, but a deep superficial burn, then yeah, so the pain caused by this burn can be potentially more than him having a fractured femur. Okay, so for example, you have a motorcycle injury, patient comes off and then the petrol explodes. The patient will have some burns on him, but he might also have a broken leg. 9 times out of 10, the patient will be complaining more about the burn than about the other injury. So never forget that there could be other injuries alongside with the burn that you have to, the patient may be distracted from, that you have to identify and treat, because other ones could be more life-threatening. So also do your full primary survey, and you need to treat your life-threatening injuries whether or not they're caused by the burn. And alongside electrical injuries as well, you need to do the whole cardiovascular exam. You need to do an ECG for the patient, and you have to have your defibrillator attached to the patient to check what rhythm they're in. All of those things are vital, and they're all going to be happening at the same time. And at the same time as you having a horrifically burnt person in front of you, you've got family members screaming. So it's just a really difficult situation to be in, and it's one that really requires leadership and command of the situation. You need to, you know, speak and be in control, because that's really what's going to mean the difference between life and death for these patients. And you need to discuss them as early as possible with the burns unit. If possible, someone in the department should be on the phone when the patient arrives saying, we've got a burn, this is how he is, can you talk us through it? Because it's a specialist injury, and it's something that needs specialist treatment, and the patient will most likely die without them getting to the burns unit.
I think that's it.
Yeah.
Eventually.
Mm.
So the final slide is if you guys have got any questions that we haven't already answered.
We've covered a lot, so I'd imagine you can send all your questions to
Norman.
To Norman, yeah.
I'm happy to take the question. Thank you, Amy. Thank you very much. That was amazing. And I'm really impressed with your presentation, contents, and also stamina. So you've been there for continuously for almost 3 hours. Thank you. You're right.
Yeah, thank you, Amy and Abdullah. I think it was a brilliant presentation, and as I said before, that you have summarized 2 days' work in 2 hours. Well done for that.
Thank you.
Yeah. So.
Thank you.
And MDMI,
both for Amy and Abdullah.
Who's the older brother?
Who's the older brother?
Yeah.
Yeah, that's the question you need to answer.
they both are younger brothers.
we are always younger to each other.
Until you're the boss.
There is one of us is dyeing his hair. Let's put it this way. Now, Amy and Abdullah, I'm really grateful. I mean, this session has been really an eye opener. And we are doing this virtual training sessions for few weeks now, and I think this has been one of the best sessions we ever had. Amy, Abdullah, you did mention about a couple of apps like the Mercy Burns one, and everybody uses smartphones these days. Are there any other apps which are free to download, which are useful in trauma settings or in looking after critically unwell patients? I know BNF is available as well, but
yeah, so the BNF is definitely available, and everybody should have that on their phone. Although I'm not sure if Pakistan follows the same British licensing for drugs, but I'm pretty sure they'd be quite similar.
Yeah, they do. They do.
They do, yeah. Okay, so in that case, the BNF is absolutely what everybody needs on their phone, to be honest. The ones I've got one called MD Calc.
MD Calc, okay.
Yeah, just type
I'll type it. That's really good for everything. It helps you in like Wells score for PE, heart score in cardiac patients.
So it helps you calculate things.
Oh wait, they're the C-spine rules, was that?
Yeah, look. Yeah, so you've got
the Canadian C-spine rules that we were talking about earlier.
Yes, I got that on my phone as well. The risk scoring, this all risk scoring basically. Yeah.
Exactly, all the risk scoring. The other ones, Talkspace.
They might not have login.
Okay.
Do you guys
Talk
have
to
a
base.
login?
I don't think so.
Does it not work? So the problem with Talkspace is it needs a faculty login. But I think you can call Talkspace and ask them or send them an email and they'll give you a faculty login. Essentially, it's an amazing app and it has essentially pretty much every poison known to man.
Not even just poison, like drugs.
Yeah, drugs, cleaning agents. So if you know the spray, like the bug spray, it'll be there. Any kind of
and not carbon monoxide,
yeah,
carbon dioxide, any gas, chemical.
And it will tell you how to deal with the poisoning from those. It tell you common conditions, symptoms, observation time that you need exactly, and investigations that you need to do, and it goes through the management of everything. So Talkspace is a really helpful app as well.
Thank you. I'm sure Mr. Iftikhar wants to say something.
No, I learned a lot. Thank you very much. It was a good revision course for me. Yeah, fantastic. Thank you.
Thank you, Mr.
You're ready to be back on the trauma on call now, boss.
I'm doing
I remember you covering vascular and doing leaking triple A's and all the trauma calls and as well as the GI on calls. I remember those days.
They were fantastic. The dinosaurs don't exist anymore, you see. So I was stopped.
Oh my God.
It's great. It was a good session. I loved it. Thank you.
No, thank you.
Thank you.
Thank you, everybody. Thank you. And we're grateful to all of you.